professor in the Department of ENT, Santosh Medical College. Today I'll be discussing about my presentation which is on physiology of hearing. As we all know that ear basically has two main precise functions in the body. One is hearing, the other is balance. In this particular presentation we'll be talking about how exactly we hear and what is the mechanism behind it. So the mechanism of a sound signal in the environment is collected by the pinna, which is the source where the whole sound waves gather, and it passes through the external canal, which is a structure almost 2.4 centimeter long. It is further divided into 1.8 and zero point 0.6 centimeter, the bony and the cartilaginous parts. And the sound wave which basically traverses through this extraordinary canal strikes the tympanic membrane, which if it is intact and mobile will gonna traverse these sound waves to the ossicles, and the ossicles will be set into vibrations. Remember, there are three main ossicles in the ear. These are malleus, incus and stapes. So the sound waves which basically traverses through the external auditory canal, they strikes the tympanic membrane, and after striking the tympanic membrane they basically set malleus, incus, stapes into vibration, and the sound is basically conducted to the oval window, which further traverses it to the inner ear, and eventually it reaches the brain. So like in this schematic presentation, you can see that the sound waves are coming. They are basically generating vibrational energy. The vibrational energy is particularly forming waveforms. Waveforms basically are the main conductive source of information, which will be further converted into the electrical signaling. The electrical signaling conversion basically happens in the inner ear and the neural aspect of the brain, and then finally it reaches to the brain auditory cortex, where it is interpreted and we basically confound it to be heard. So the whole hearing process basically has this much to do. Now if we have to dissect deep, so we will divide it into mechanical conduction of sound. Means there is a source which has produced the sound. The sound will always generate few sound waves. A large amount of energy is lost when air conducted sound travel into cochlear fluid. This is basically explained by the different sources of encounteration during this whole process. This loss of sound energy is compensated by the middle ear, which convert sound of greater amplitude but lesser force. This is called impedance matching system. And this impedance matching system and mechanism is basically explained by the middle ear fluid. And as we know that the kinetic energy of anything which basically traverses through the liquid or effused medium will have a proper implication of impedance matching, as it is explaining. Now there are few more important things which we have to include when we talk about the physiological conductance. The lever action of ossicles, this is very important. Now for that we have to understand that the handle of malleus is 1.3 times longer than the long process of incus, providing mechanical advantage. If it is longer than the long process of incus, obviously the mode of vibrations, the conversion of energy will have a lot more felicitation. Then the other thing is hydraulic action of tympanic membrane. This hydraulic action of tympanic membrane is because the area of tympanic membrane is larger than the area of stapes. The average ratio between the two being 21:1. Now, this is a very simple understanding. If there is a difference of 21:1, then obviously a lot of energy will get lost during this process. Now, the third thing is curved membrane effect. Because the tympanic membrane is obliquely placed and it is curved, the movement of tympanic membranes are more at periphery than at the center. So what basically it holds true for? It holds true for that the effective ratio becomes a bit less. It is not exactly 21:1. It becomes a bit less. Precisely, it becomes 18:1. Now, we know that the middle layer has two windows, the round window and the oval window, and there is a natural phase difference between oval and round window, and this phase difference is very important in the proper conductance and interpretation of the sound. Now we have to understand it by this way, that the sound waves striking the tympanic membrane do not only reach the oval and round window simultaneously, because the oval window is receiving wave of compression which is directly through the movement of the ossicles, and the round window is at the phase of diffraction because the sound is coming directly to round window and hitting it. So if the sound wave strikes the window simultaneously, both of them, they would cancel each other. This acoustic separation is achieved by the presence of intact tympanic membrane and a cushion of air in the middle ear around the round window. It can be explained very nicely and easily that oval window is basically masked by the stapes footplate, and the stapes footplate is in continuation with the tympanic membrane through its attachment with malleus and incus. But the round window is basically shielded by the air around it. So obviously the conductance will have a bit of difference, but it will not be more in an intact tympanic membrane case. Now the natural resonance of external and middle ear. The external ear canal has a natural resonance of 3000 Hz. The middle ear has a natural resonance of 800 Hz. These are few frequencies to be remembered. Now the greatest sensitivity of sound transmission is 500 Hz and 3000 Hz. The second will be transduction of mechanical energy to electrical impulses, because that is what which will matter the most, because ultimately everything has to be conducted to brain in the form of electrical impulses. So when the movement of stapes footplate is happening, what exactly it is up to? It will basically set the whole cochlear fluid, as you know, endolymph, perilymph, into vibration, and this vibration will further gonna shake the basilar membrane, which is part of organ of Corti, or you can understand deep physiology of inner ear, and set everything into vibration. And this also set up a shearing force between the tectorial membrane and the hair cells. All this tectorial membrane, basilar membrane and hair cells basically are part of inner ear and the organ of Corti. Now this distortion of hair cells, because of this setting of electrical impulses and the movement of fluid, give rise to cochlear microphonics, which trigger the nerve impulse. So till now what we have understood, that the sound is coming in the form of conduction. The whole mechanical energy which has traversed through oval window, and the phase difference between oval window and round window, this will basically set the cochlear fluid into the vibration, and the cochlear fluid basically will start microphonic changes in the pathway of physiology of conductance. Now next we will talk about the neural pathway. So as the diagram is clearly explaining that the whole neural pathway, you see there is a interpretation starts at the level of neural interpretation starts at the level of cochlea. From cochlea there is vestibulocochlear nerve. The vestibulocochlear nerve brings the information through ventral and dorsal cochlear nuclei. Now these ventral and dorsal cochlear nuclei will further bring the information to superior olivary complex, and while passing through superior olivary complex they will have trapezoid bodies on their way. When they have come to superior olivary complex, they will pass through the lateral lemniscus, and this lateral lemniscus will have its own nucleus called as nucleus of lateral lemniscus. So when it reaches the nucleus of lateral lemniscus, it will further carry the information to inferior colliculus. Now from inferior colliculus, this information will be further carried to the precise area of brain called as medial geniculate body, and from medial geniculate body it will go to the proper area of interference in brain, which is the auditory cortex, or also called as area 41. So it's not very hard to remember. If you starts from the cochlea or eighth nerve, you will basically have to remember that it will go to which place? It will go to superior olivary complex, and from there it will go to lateral lemniscus, and from there it will again go to inferior colliculus, and from there it will go to medial geniculate body, and from there it goes to auditory cortex. If you have to remember it, if you you have to remember the auditory pathway, I always suggest a mnemonic for that, which is the same you must have heard while interpreting bara, like we call it E. coli ma. E is eighth nerve and cochlea, EC, then superior olivary complex, then the lateral lemniscus, then the inferior colliculus, then the medial geniculate body, then the auditory cortex. See, this is very important to understand and remember, because this has got a lot of clinical implication. If you remember this whole auditory pathway, you will have a very good amount of understanding if a deaf child comes to you, or anyone who has a deaf presentation, and you want to be very precise about which steps in the neural pathway will have the propensity of the disease matching. So based upon the different propensity or the correlation of the neural pathway disturbances, we can assume that what will be the available treatment modality for the same deaf patient. Now let's understand something about the electrical potentials of cochlea and cranial nerve 8th. So to understand that, we have to basically know that there are 4 types of potentials which have been recorded. They are first is endocochlear potential. It is a direct current potential recorded from the scala media and is around 80 millivolt. It is generated from the stria vascularis by sodium potassium ATPase pump, and it provides source of energy for cochlear conduction. Now the other is cochlear microphonics. Cochlear microphonics is when basilar membrane moves in response to sound stimulus, as we saw during the understanding of whole this process. So the electrical resistance at the tip of hair cell changes, allowing flow of potassium through hair cells and produces voltage fluctuation called cochlear microphonics. You know that it is very important for brain to interpret. The third is summating potential. The name itself is summating. So it is a DC potential, direct current potential, and follows envelope of stimulating sound. It is produced by hair cells. It may be positive or negative, and it is superimposed on 8 nerve action potential. The fourth is compound action potential. It is an all or none response of the auditory nerve fibers. Now let's talk something clinical pertaining to this whole understanding of the physiology of hearing, and it is called as hearing loss. A person who is not able to hear as well as someone with normal hearing, the hearing threshold of 20 decibel or better in both ear is said to have hearing loss. So hearing loss may be mild, may be moderate, may be severe or profound. It can affect one ear or both ears and leads to difficulty in hearing conversational speech or loud sound. Now the deaf people have profound hearing loss, which implies very little or no hearing. They often use sign language for communication. This won't be the problem for mild to moderate cases, moderately severe cases, but in cases where there is a profound hearing loss, this can be a big problem. Risk factors of hearing loss. The risk factors, one of the most important is aging. Exposure to sounds over the years can damage the cells of your inner ear. Hereditary. Genetic makeup may make you more susceptible to ear damage from sound or deterioration from aging. Occupational noises, where there is so much of heavy working, industrial working, loud noises is involved. Jobs where loud noise is a regular part of the working environment, such as farming, construction or factory work, can lead to damage inside your ear. They basically damage the hair cells. Recreational noises, exposure to explosive such as firearms, jet engines, bomb, pistols, can be leading to immediate or permanent hearing loss in such workers or the people who are exposed to them. Now, some medications can also give you hearing loss. These are aminoglycoside antibiotics like gentamicin. There are many chemotherapy drugs which comes into this category. They can damage the inner ear. Both of them can damage the inner ear. Now, temporary effects on your hearing like tinnitus or hearing loss can occur if you take very high doses of aspirin, other pain relievers, antimalarials, loop diuretics. Besides this, there are some diseases also that result in hearing loss. For example, meningitis. In meningitis, what can happen? In meningitis, you can have a ossification of cochlea post resolution of meningitis, also called as cochlear ossificans, and this gives a almost a permanent type of hearing loss. So if we have to basically categorize the hearing loss will be of two types: conductive hearing loss and sensory neural hearing loss. The conductive hearing loss is basically the disturbance of the conductive apparatus of the ear. Then there is one more special type of hearing loss which is called as mixed hearing loss or mixed conductive and sensory neural hearing loss. This can be seen in middle ear conditions. This can be seen in temporal bone fractures, where you see that the injury will basically traverse through the ossicles, will damage the eardrum. It will also pass through the inner ear. Now, this is one very important classification WHO has given to basically categorize the hearing loss. So to categorize this hearing loss, we basically interpret the hearing loss by doing a pure tone audiogram investigation. So the mild category of hearing loss is when there is a hearing loss of 26 to 40 decibel. The moderate hearing loss is when the hearing loss is 41 to 55 decibel. The moderately severe hearing loss is when there is a hearing loss of 56 to 70 decibel. The severe hearing loss is when there is a hearing loss of 71 to 90 decibel, and the profound is when it is more than 91 decibel. So I am repeating it again. Mild is 26 to 40, moderate is 41 to 55, moderately severe is 56 to 70, severe is 71 to 90, and profound is more than 91 decibel. So you have to basically see your pure tone audiogram, and then based upon the intensity or severity of hearing loss, you have to basically categorize the hearing loss for that. Now, what happens basically when the hearing loss has happened, and what will be its clinical manifestation? We will discuss about it now. So there will be muffling of speech and other sounds. There will be difficulty in understanding words, especially against background noises or in crowd of people. Okay, but there is one condition where this thing can go a bit advantageous, like loud noisy atmosphere. In diseases like autosclerosis, there is a phenomena called as paracusis wilsi, means this patient starts hearing better in loud atmosphere, for a very simple reason that in loud atmosphere many people whom he would be talking to will gonna raise his voice. If they will raise their voices, the patient's threshold of hearing loss is crossed and he or she starts hearing well. But this only happens in otosclerosis. Otherwise, most of the time there will be a difficulty in understanding words, trouble hearing consonants. Okay, because consonants are very small base sound, so there will be trouble hearing consonants, frequently asking others to speak more slowly, clearly and loudly. So all these three situations are possible based upon which type of hearing loss the patient is suffering from. Needing to turn up the volume of the television or radio because to cross the threshold of hearing loss. Withdrawal from conversation because of lack of confidence as he is not able to hear. Avoidance of some social settings because it can have a mental impact too. Okay, if I'm not hearing, how come I can go to these places? So they basically starts avoiding these sort of scenarios in their life. But the thing is, whatever it is, we now have understand about the physiology of hearing, what are the type of hearing losses, what can be their symptoms. So as a budding doctor, we must be very thorough in diagnosing few things. Okay, like air conduction, conventional or standard audiometry is a tool which can be used to basically test all the hearing losses and to have a good diagnosis by testing. You can do a bone conduction. In clinical methods, you can have Rennie's and Weber's test to confirm the and categorize the quantity and quality of hearing loss. It's audiometry. To basically see about the middle ear pressure, you can go ahead and do a tympanometry. You can also do an acoustic reflex testing just to see the stapedius muscle, how exactly it is working. Sometimes it also helps in a cochlear and retrocochlear hearing loss categorization and to establish otosclerosis also precisely. Then the word recognition can be done. Acoustic emittance is a very nice technique which is to be practiced when the hearing loss cannot be specified accurately. Autoacoustic emissions is a very good tool, especially in the newborns. Like this is a tool which basically gives us a very good hint about the neonatal hearing loss. And The most objective test of any hearing loss, auditory brainstem response ABR, also called as BERA, can also be done. We already had a good amount of understanding about the hearing cycle. So based upon the place where the wave formation is absent in BERA, we can predict and recognize the hearing loss. So with this, I'll be finishing off today. Hope to meet you soon with a new lecture.